Hello, everybody, and welcome to this new webinar about multiple myeloma in labs, a look inside the black box. Ooh, how exciting. What's in that black box? So introducing Dr. Ronald Booth today, who is a clinical biochemist at the Ottawa Hospital in Ontario. Welcome.
Thank you.
Hi. So my name is Karen Gravel. I'm regional manager responsible for education and community engagement, specifically for the provinces of Quebec, Nova Scotia, New Brunswick, and PEI. And I'm introducing my colleague Chantel. Welcome.
Hi, everybody. I'm Chantel Wicks. I work with Myeloma Canada. I am the Regional Manager of Community Engagement and Development, specifically for the provinces of Ontario all the way to BC, the territories in Nunavut, as well as Newfoundland and Labrador.
Wonderful. So before we start this webinar, I'm going to share my screen for small instructions regarding this webinar. You can all see my screen, Chantal? Right. Okay. So thank you to all our sponsors, without whom it would not be possible to make available all this great educational material for our community of patients. So as you can see, we just can see the panelists today. We cannot see your screen as a participant. So the way we will interact today will be with the Q&A panel. So if ever you're on a cell phone or a tablet, sometimes you just have to swipe on the side to access the menu bar. So please take the time to locate the Q&A. And I encourage you to ask your questions throughout the presentation. Of course, we will wait until the end, but just so you don't forget what you want to ask. Okay. So after this presentation is finished, we will make sure to make it available for our community of patients. So the way to access the video will be if you type in our website, myeloma.ca. You go to the resource library, as shown on the screen. When you go down, after you see all the info guides and info sheets, you'll get to that section about our channel. Click on it. You'll get to our YouTube page. Of course, you can search for Myeloma Canada directly on YouTube. If you see our red flower, you're at the right place, and you have access to videos, but also you can sort by playlist and have access to all those great presentations that we have recorded in the past. And if you hit subscribe, you will be notified every time we load something. Quick reminder, if you want to join MC Lounge, it's a private community for patients and caregivers if you want to chat with other people. MC Assistance was just launched recently. Actually, it's a information line if you have questions about myeloma, treatment, side effects, or if ever you just want to talk with somebody or ask questions about services in your area. Also, quick reminder to subscribe to our newsletter if you want to be notified once a month by email about all the updates about myeloma. All right, I'm going to unshare my screen. I'm sure you all want to hear more about the labs. Dr. Booth, to you.
All right, I'll share my screen. All right. Okay, so I'm going to hopefully give everybody a little bit of a look inside the laboratory black box. Talk might be a little bit technical, but I'm hoping that I'll explain it in a way that everybody can understand. And obviously, if you have any questions, like was said, feel free to post them, and I'll do my best to answer them. So a little bit about me, so you know where I'm coming from. I'm a certified clinical chemist and a fellow of the Canadian Academy of Clinical Biochemists, as well as a fellow of the American Association of Diagnostic and Laboratory Medicine. I'm a clinical biochemist at the Ottawa Hospital and the Eastern Ontario Regional Lab Association, where we provide service and care to one of the larger myeloma programs in Ontario. I'm also a full professor in the Department of Pathology and Lab Medicine at the University of Ottawa. And more recently, I'm the founder and past chair of the Canadian Society of Clinical Chemists Monoclonal Gammopathy Working Group, where we generated some recommendations for laboratory assessment of multiple myeloma and how the laboratory reports our results to patients and clinicians. So a little bit about lab medicine in general, because I think a lot of people aren't familiar with what happens in the lab and sort of how important the lab really is in terms of medicine. So within hospital labs, the labs are generally broken up into either anatomic pathology. This is where pathologists are looking at biopsies or cytology and making diagnosis. There's also something called clinical pathology, and this is where I live. I live in the biochemistry lab. There's also microbiology, where we're looking at diagnosis of infectious diseases like viruses and bacteria. The microbiology lab was key during the COVID pandemic. There's also the hematology lab, where they look at the blood cells, and transfusion medicine, or often referred to as the blood bank. In private labs, if you have them in your province, they usually consist of very similar labs: biochemistry, hematology, microbiology, anatomic pathology. But generally, there's no transfusion medicine because most people aren't going to a private lab to get blood transfusions. In terms of laboratory medicine staff, we have quite a varied number and quite a large number of individuals that work in the lab. So we have anatomic pathologists. These are MD, trained with subspecialist training in anatomic pathology. Most of their job is looking at biopsies under a microscope, but they also do a number of other things such as autopsies and whatnot. Clinical pathologists are broken down into microbiologists, biochemists, geneticists, and hematopathologists. And depending on the role you play in the clinical pathology lab, you can either be an MD trained or a PhD trained. I happen to be a PhD trained, and all of us have to have subspecialty medical training to do the job. So we can be we can work in the biochemistry, the microbiology, or the genetics labs, and hematopathologists are MD only. We also have a large number of medical laboratory technologists who do the majority of the sort of the lab-based work and prepare the samples and do a lot of the testing. And we also have a fair number of laboratory technicians who assist medical laboratory technologists. So in the labs, there is a lot of highly trained individuals that work to diagnose and generate all the lab results that physicians and nurses look at. So on with the talk, I'm just going to give a very brief background in multiple myeloma. I'm sure most of you are aware, but I'm going to focus on sort of the bits and pieces that are important in the lab. So multiple myeloma is a cancer of the plasma cells, which are the antibody-producing cells in the body. These plasma cells normally live in the bone marrow and aren't normally floating around in the blood, and that's why we have to do bone marrow biopsies to get a good understanding of what's going on. Early on in multiple myeloma, there's generally no or very minimal symptoms, and then as the disease progresses, you can end up with bone pain, anemia, kidney disease, and you may also have an increase in infections. Multiple myeloma normally progresses from a pre-malignant stage called monoclonal gammopathy of undetermined significance, or MGUS, and then as it progresses, it goes through something called smoldering myeloma and eventually to full-blown multiple myeloma. All patients with multiple myeloma start with MGUS, but the majority of patients with MGUS don't actually progress on to multiple myeloma. Somewhere between 0.1% and 1% of patients progress from MGUS onto multiple myeloma per year, and the probability of progression depends on a number of different factors. Many of them are laboratory-based that help risk predict who is at risk of progressing to multiple myeloma. The reason why I'm talking about MGUS is because MGUS is actually a laboratory diagnosis. Much of medicine is based on a mix of clinical and diagnostic imaging or laboratory medicine to make a diagnosis. But in the case of MGUS, it's actually a laboratory diagnosis. What this is the presence of a monoclonal immunoglobulin, and we'll talk about that shortly, is identified in the blood, but the patient has absolutely no symptoms or evidence of any malignant disease. So when we talk about monoclonal proteins and monoclonal immunoglobulins present in the blood, what are they? So immunoglobulins are produced by B cells in the case of IgM and the plasma cells, which are malignant in multiple myeloma. Production in a healthy individual increases with the immune system activation for inflammation or infection. These antibodies, as you can see here, there's a number of different ones. They're composed of a heavy chain and a light chain. And these antibodies bind to proteins, bacteria, viruses, and any other foreign substance that enters the body to help fight it and clear it from the body. And as you can imagine, each antibody has a unique ability to bind to a single target. So we need many different antibodies to actually generate a robust immune response. So we have one antibody that targets one antigen. So we need a whole bunch of different antibodies to sort of interact with a gamut of different viruses and bacteria and protein that we can encounter. So there's a number of different antibodies that can be generated. There's IgM, which is produced by B cells. It's sort of the first immunoglobulin that's produced during an infection. We have IgG and IgA antibodies. IgG is interesting because it's actually secreted into the mucous membranes to help protect those from infection. And then we have IgE and IgD. So multiple myeloma, the most common form has an IgG monoclonal immunoglobulin, then IgA. IgM is also a possibility, and very, very rarely we can have IgE or IgD monoclonal multiple myeloma. So since we have very different antibodies generated, and each antibody has to have a different we'll call it a binding domain to interact with these different antigens and different viruses and bacteria that are present, we have to have a huge number of different antibodies generated. So it's thought we can make somewhere between 10 to the 9 or 10 to the 12 different antibodies. So that's a billion or a trillion different antibodies that the body can make. The way this happens is that there is something called a genetic recombination while these immune cells, these B cells and plasma cells, are developing in the body. And what happens is that there are a number of genetic segments, the V, D, and J segments, that recombine and get connected together to generate an antibody. And what happens is that the pieces that are connected, the other pieces are left behind. So they get deleted from the cell, and that new B cell or plasma cell can only make that one kind of antibody. But since we have millions or billions or trillions of different plasma cells and B cells in our body, we make this vast array of antibodies, and we call this polyclonal immunoglobulins or polyclonal antibodies. In a healthy individual, you probably have somewhere around 10 to the 9 or a billion different antibodies floating around in your blood. So we can measure all these different antibodies, and they're all coming from different plasma cells or B cells. In the case of multiple myeloma, what happens is there is a single plasma cell that becomes malignant or cancerous and starts to over-replicate. And since it's one single plasma cell that's replicating, it's producing only one kind of antibody. They're all identical, and there's a whole bunch being produced at the same time. So we term this monoclonal antibodies or monoclonal immunoglobulin. And the reason why this is important in a lab context, we can measure this monoclonal immunoglobulin and use it as a biomarker for the disease. So now we'll get on with some laboratory testing. So in terms of laboratory testing, there's various different labs that are involved in multiple myeloma testing. We have molecular genetics and flow cytometry labs, where these labs are looking at the genetic alterations that we find in these malignant plasma cells. Or we're looking at the different receptors that are present on the surface of the plasma cells, and knowing which markers are present on the surface of the cell or which genetic mutations are present in the cell, we can end up risk predicting who's at higher risk for multiple myeloma and who's at a lower risk. There's also the hematology lab, where they look at the cells in your blood by a complete blood count. They look at the bone marrow biopsy and a peripheral blood smear, and look at the cells that are present in the blood to help monitor and diagnose. And in the biochemistry lab, we do a whole bunch of different analyses, looking at everything from total protein and albumin in your blood, calcium, creatinine, which is a marker of renal function, the different immunoglobulins, lactate dehydrogenase, which is an enzyme which is helpful in risk prediction, along with beta-2 microglobulin, which is helpful in producing a risk prediction. We do serum protein and urine protein electrophoresis, and we measure the serum-free light chains. I suspect everybody on this webinar has had their blood taken at least at one point in their life. And don't know if anybody's wondered why the tubes have different colored tops. It's because the anticoagulant that is present in each one of the tubes is differentiated by the top color. So if we're looking for serum, which is generated when we clot the blood, and it's the liquid component that's left over, we will collect the blood in red top or gold top, where there's no anticoagulant and the blood clots in the tube. Or in most cases, we use a light green tube, which is heparin, which is an anticoagulant, and it stops the blood from clotting. In hematology, they use a lavender top tube or a purple top tube, and this is because they want a very strong anticoagulant. It's called EDTA, and it chelates or it binds up calcium. And because they want to see the cells in the blood, so they want to look at the whole blood. And it's really important the order that we draw this blood, and we use these tubes. An example is that if we were to draw the EDTA tube ahead of the serum or the heparinized plasma tube that we use in chemistry, even the tiniest drop of EDTA, if it got mixed in with the serum or plasma, it's going to falsely decrease the amount of calcium and magnesium that we're measuring. And we could falsely identify a patient with low calcium when they really don't, just because of this tiny bit of contamination. So we have to be really diligent in making sure that the order that we draw the tubes in is correct, so we don't cause any contamination. When the lab receives the specimen, we have to process the specimens. So in the case of hematology, they're looking at the cells. So they look at the whole blood, so we don't do any separation for their analysis. But in chemistry, we need the serum or plasma, which is the liquid phase of the blood. So if it's a serum, we allow the tube to clot, and we generate a clot in the blood, and then we can separate the serum from the clot. In a similar way, we can separate the cells from the plasma. And we do this by centrifugation. So we spin the tubes very, very rapidly, and this induces a centrifugal force and separates the cells from the plasma. The cells migrate to the bottom of the tube, and the plasma migrates to the top. But we have this really interesting technology that we use in these tubes. It's called a thixotropic gel. So what it is, this gel, it's got interesting properties where when you apply a force, like a centrifugal force or gravitational force, it liquefies. And the density of this thixotropic gel is in between the density of cells or clots and serum. So when we centrifuge it, this gel liquefies, migrates up to the top of the cells, and separates the cells from the serum. So we have a very clean serum or plasma sample, and we don't have to worry about any cells contaminating the serum or plasma. These are the an example of the biochemistry analyzers that we have in the lab in Ottawa. And these large chemistry analyzers, they are more or less fully automated. They take the tube of blood and they can measure the different components. Usually somewhere between 50 and 70 different components can be measured on the same analyzer. And they can actually measure between 500 and 1,500 different tests per hour. So we can measure quite a lot of different tests quite rapidly. So for example, at the Ottawa Hospital, we do about 6 million biochemistry tests per year. So we have a number of these analyzers in our lab. So the way these biochemistry analyzers function is something called spectrophotometry. So in spectrophotometry, we're essentially measuring increases or decreases in light. And this is the electromagnetic spectrum. Normally, we're looking at visible light or near visible light. And what we can do is we can measure increases or decreases of specific wavelengths of these lights. And an example of that people may find interesting is the reason why plants' leaves are green. So inside the leaves, we have a couple forms of chlorophyll. And these chlorophyll, they absorb light in the blue range and the red range. So this light is absorbed. Since it's absorbed, we can't see it. And we have reflected light that is green. And that's why the plants appear green to us. And we can use a similar idea where we're measuring different wavelengths, different colors of light, and whether there's an increase or a decrease in this, we can determine what concentration of different analytes are present in the blood. So in the case of total protein, albumin, and calcium, we have specific dyes that bind to these proteins or molecules, and when they bind to them, they change color. So in the instrument, there's a light. There's a sample called a cuvette. That's it's actually quartz, and the light can pass through it. So we have our sample here that binds with this dye, and then we have a light detector that can measure very specific wavelengths on the other side. So when we pass the light through it, depending on the concentration of whatever, either total protein or albumin or calcium, as the concentration increases, we have a decrease in the light that goes through the sample because the sample is absorbing it. And the amount of decrease or absorbance, the amount of increase in absorbance, is proportional to the amount of these analytes. In a similar manner, we can actually look at, instead of absorbing light, we can look at scattering of light. So for some proteins, the immunoglobulins, for example, we don't have any binding dyes that can bind to them and change color. So we use an antibody to actually detect these antibodies. So what we have are small latex beads that are coated with antibodies that will interact with either IgG, IgA, or IgM, or beta-2 microglobulin, or any protein that we wanted. And when the antigen, whatever we're measuring, is present, it ends up forming a complex, an immunocomplex, with these beads and the antigen that you're interacting with, that you're trying to measure. And these immunocomplexes are large enough to scatter the light. And so what happens is the light gets scattered. And a good example of this in sort of the real world is why clouds are white. So light from the sun interacts with the water particles in the clouds, scatters the light in all directions, and forms a cloud. So what we can do is we have a light in the instrument. Again, we have a cuvette and we have these particles, and it scatters the light. And instead of the detector looking at a decrease in the amount of light that goes through the sample, we have a detector that's offset at an angle, and it actually detects an amount of increased scattered light. And the amount of scattered light is proportional to the amount of whatever you're measuring in the blood. The last way we can use spectrophotometry in the lab is actually an enzymatic reaction. So one of the markers that we use to help risk predict patients with multiple myeloma, we measure an enzyme called lactate dehydrogenase, or LDH. LDH is an enzyme in the blood that converts lactate to pyruvate. So in this cuvette, we can have lactate and something called NAD. And the amount of lactate in the blood actually converts lactate to pyruvate and NAD to NADH. NADH has this wonderful property that it increases the absorbance of light at 340 nanometers. So that's just below what we can see with our eyes. And so, but this detector here can measure that. And as there's an increase in absorbance of light at 340 nanometers, we can measure that and determine how much lactate dehydrogenase is present in the blood. So these biochemistry analyzers use a whole bunch of different techniques that are based on light absorbance or light scattering to determine the amount of these different compounds in the blood. Hematology, on the other hand, they're looking at the different types of cells that are present in the body. So just to remind everybody, way back in grade school and high school, what we're looking at, we have sort of the standard cell. And since I'm going to show you some biopsies, I'll give you a little bit of information, interesting pieces that we're going to look at. So we have the nucleus, which is present in the cell, and we have the cytoplasm. And in this case, I'm indicating the Golgi complex because that will become relevant when we look at the different cells. But in hematology, we're both counting the types of cells and we're counting the number of cells and counting the types of cells as well. So we have an instrument called Complete Blood Count Analyzer, or CBC analyzer. And this is a really interesting piece of technology. Essentially, it's something called a flow cytometer. So what it does is it takes the cells from your blood and it has the ability to line them up so that only one cell at a time flows through something called a flow cell. And as the cells pass through this flow cell, it can determine the size of the cell, and then it knows what type of cell it is and it can count them. So when we're counting the number of red blood cells, this instrument can count the number of red blood cells. It can also determine excuse me, the type of cell, excuse me. Just getting over a cold. So it can also determine the different types of white blood cells that are present in the body. We have a whole bunch of different types of white cells. And it uses a similar technique with light where it lines up the cells and one passes through this flow cell at a time. And depending on where we look at the light, the amount of light that passes through it can help determine the size of the cell. And then the amount of light that's scattered is dependent on the complexity of the cell on the inside. So we have two detectors, one that goes where the light goes straight through and one that's off at an angle. And then if we plot this on this light versus the complexity light, we'll call it the forward scatter and the side scatter, you can end up plotting these different cells. And you can see there's lymphocytes and monocytes and neutrophils and different types of cells, and we can count them. So these CBC analyzers can do a very in-depth analysis in all the different types of blood cells that are present in the blood. So after we've counted the blood cells and we have an idea of how much hemoglobin and how many red cells and how many white cells are present in the body, often what happens is we do a peripheral blood film. So we do a smear where we take the blood and we load it onto a slide, a microscope slide. We stain it, and then we can view it under a microscope. This is a normal, healthy individual, and you can see all these little sort of pink dots. Those are your red blood cells containing hemoglobin. That's why they're pink, and a few immune cells. In the case of multiple myeloma, something happens, and this is due to the presence of a high concentration of immunoglobulins in the blood from the multiple myeloma producing immunoglobulins. The red cells tend to clump, and they stack up. And when you see red cells stacked like this is called rouleau. And this is due to the fact that the red cells normally are negatively charged and repel one another, and they don't want to touch each other. But the protein, the extra protein that's present from the immunoglobulins, coat the red blood cells and allow them to stick together and stack up. So seeing rouleau is a hallmark that we see in many patients with multiple myeloma. Sadly, I think many of you may have had bone marrow biopsy. And One of the ways that we look at the bone marrow biopsy is looking at the bone marrow aspirate. So this is when they're doing a bone marrow biopsy and they extract a little bit of fluid and they smear this on a slide and they stain it, and then they can review it under a microscope. So this is a normal, what we see normally, and it's just a mix of cells, the odd plasma cell that's present, but it's a nice mix of cells from a normal individual. Patients with myeloma, since we have an increase in the number of plasma cells in the aspirate, we see an increase in the number of plasma cells. And these red arrows are indicating the various plasma cells. And you can see they have a nucleus, they have a large cytoplasm, and they have a very light area here, which is called the HOF. And this is actually where the Golgi complex is producing the immunoglobulins. So normally, we don't see so many plasma cells present in a bone marrow aspirate. When we have the actual biopsy itself, it's extracted from the core, it's fixed, and then it's decalcified to remove the bone. It's then embedded in paraffin wax, and then it's sliced in very, very thin slices and then put onto slides for hematopathologists to review. This is what we see when we look at bone marrow biopsy. And I'm just zooming into this area here. The stain is highlighting the presence of plasma cells. And you can see this purple color, these are the plasma cells. Normally, there's less than 3% plasma cells present in a bone marrow biopsy. And you can see here that almost every cell that we're seeing is a plasma cell. So this is a hallmark of a diagnostic for a patient with multiple myeloma with this number of plasma cells. We can also do some immunostaining because I've mentioned briefly before that each immunoglobulin comes from a different plasma cell and it's unique to that plasma cell. So in the case of multiple myeloma, when it's producing its monoclonal immunoglobulin, the light chain component can either be kappa or lambda. So we can stain for either kappa or lambda light chains. And you can see in this case, the brown color is positive for staining for kappa light chains, and there is no brown in the lambda staining. So we know that this patient has a monoclonal protein that is, the light chain is the kappa, and they're not producing lambda light chains. In a healthy individual, you would have a mix of both kappa and lambda light chains in a biopsy, and less than 3% of the cells. And here you can see it's essentially 100% of the cells. So in the chemistry lab, we're back there now, and one of the tests that we do is called protein gel electrophoresis. And what we can do here is there's a nice feature of the proteins in the blood. They tend to group when we add them to a gel. So any sort of gel matrix, in this case, it's agarose gel. And the interesting thing is that proteins are charged. And what we can do is we can apply an electric current to the serum that's loaded onto a gel. And what happens is the proteins migrate in different directions based on their charge. The proteins tend to group together and produce different fractions. And you can see here, this is essentially what the protein electrophoresis looks like. So we have albumin, and then we have different groups of proteins. When we look at it in the biochemistry lab, each one of these lanes is a different patient. And we add the serum, it's actually in the middle around here, and some of the proteins migrate in the gel towards the anode, some towards the cathode. And the proteins tend to group in different fractions. So we have albumin, we have alpha-1 globulins, alpha-2 globulins, beta globulins, and the gamma globulins. This is where the immunoglobulins all live. And if you remember back to the beginning when I talked about polyclonal immunoglobulins, where each different immunoglobulin is different, they have slightly different protein or genetic sequences, which makes them have slightly different charges. And you end up with this smear of immunoglobulin. So this is what a healthy individual looks like. If you have multiple myeloma and you're producing a monoclonal immunoglobulin, so the plasma cells that are malignant are producing only one type of immunoglobulin, it clumps together and you see this band present in the serum. So this is the hallmark of the presence of a monoclonal immunoglobulin. And anybody who has been treated with some of the biological treatments, in particular daratumumab is a monoclonal antibody treatment, and patients that are on daratumumab, we can actually measure that, and we see that in their blood as a band down near the bottom of the gel. So when we're reading these, we have to know if patients are on a monoclonal immunoglobulin therapy or a biological therapy so that we don't mistakenly say that they have a monoclonal protein when it's actually due to the drug. We can also do urine protein electrophoresis, a little bit more complicated, a lot more proteins that are present in the urine. But the take-home message here is that all of these patients have a fair amount of protein. They've got albumin and other proteins present. If you have a normal, healthy kidney, you really don't see any protein present in your urine, or very, very little, like even less than this one here. So again, we're looking for the presence of monoclonal immunoglobulins. This would be an example of a monoclonal immunoglobulin present in the urine. So we have a nice computer system that takes our gels and it does something called densitometry. So what it does, it's basically a scanner, and it scans the amount of dye of protein. If we go back here, the amount of protein that is present, and it does a tracing of the amount of protein that's present in each lane. The system then identifies the different fractions. So this is your albumin, alpha 1, alpha 2, beta, and the gamma globulins. And then what it can do, we also measure the amount of total protein that's present in the blood. And the system looks at the percentage of each one of these fractions, and then it can determine the amount of protein that's present in each fraction. This is an example of a healthy individual. This is a patient with multiple myeloma, where we can extract the monoclonal protein here, and we can quantitate the amount of monoclonal protein present and use that as a biomarker for how much multiple myeloma the patient actually has. So the more disease they have, the more plasma cells they have, the higher the concentration of the monoclonal immunoglobulin. So when you're being treated and the number of cancer cells are dropping, the monoclonal protein concentration also drops. And this is an example of how we often monitor it. This is an example straight from our computer system, where we have patients with a monoclonal immunoglobulin. This patient had a very, very high concentration, and it dropped with treatment, and it's quite low now. This is another individual with a sort of a medium to low concentration monoclonal protein, and we can track it over time. So when we do see an abnormality on the gel electrophoresis, we have to find out first we have to make sure that it is truly a monoclonal protein. And the way we do that is we do something called immunofixation. So if we see a band on the gel, we do our immunofixation, where we can identify the presence of the different isotypes, so IgG, AM, kappa, and lambda. So here we have a protein here. This is the same patient, and it reacts in the IgG lane and the kappa. So this tells us that patient's monoclonal protein is IgG kappa. We can do similar things with urine. So sometimes patients have monoclonal proteins both in the serum and in the urine. And often in the urine, they have something called a free light chain, which is just a small component of the immunoglobulin. So if we see that, we can do the immunofixation for the serum. In this case, we have IgG kappa again. And we can see a little bit of light chain here only. There's no reaction in any of the IgG ARM fractions, only kappa. So we suspect that that's a free kappa light chain. And when we look in the urine, we have high concentrations of kappa light chains with a little bit of IgG kappa, which corresponds to our gel here, where we have IgG kappa, and the free light chain in the urine. So we can work through analysis that way. just going to skip this slide. And the last piece I'm going to talk about are serum-free light chains. I think most people have an idea of the utility of serum-free light chains and how you monitor your numbers. But I'm going to give a little bit of information about what it is and how we use it and how we detect it. So healthy plasma cells from individuals produce immunoglobulins, and we tend to overproduce the kappa and the lambda light chain components because we have the heavy chain here and we have the light chain here. So we produce too much kappa and lambda light chains. And these just end up spilling into the blood, but they're quite low concentrations. Patients with multiple myeloma, these cancer cells tend to overexpress the extra kappa or lambda light chains, much more to the point where we can actually see them. And that would be an example in the urine where you can see free light chains. There's a relatively new assay called the serum free light chain assay, where antibodies to detect these have been generated against this hidden section of the free light chain. So if we have a whole immunoglobulin, we'll say this is IgG, the antibody can't get in here to detect this little hidden surface. But when there's a free light chain, when it's floating around in the blood all by itself, the antibody can bind to it and we can detect it. And in patients with multiple myeloma, we talked about how they produce just one type of immunoglobulin, either kappa or lambda. So we can look at the ratio of kappa or lambda to determine if there is overproduction of one versus the other. The normal patients, the ratio is give or take around 1. In patients with multiple myeloma, you either have a high amount of kappa or a high amount of lambda. The way we measure these is it's on the chemistry analyzer, and it's the same idea where we have our little latex beads that are coated with antibodies that detect the free light chains and only detect the free light chains. When they're present, it produces this immunocomplex. And then in the chemistry analyzer, it scatters light, and we can determine the amount of extra kappa or lambda that's present. When we look at these serum-free light chains, we actually do 2 different analyses. We do one for kappa and one for lambda. And we can look at the absolute concentration of the kappa and lambda, and we can also look at the ratio. So the ratio gives us a good idea and helps us separate the healthy people from the people who have multiple myeloma. So if you're a healthy individual, your ratio of kappa to lambda is generally around 1, give or take. If you have a kappa myeloma, an IgG kappa or an IgA kappa monoclonal immunoglobulin, you have an excess of kappa and a high ratio. If you have a lambda light chain that's just coming from your multiple myeloma, so IgG lambda, for example, you have an excess of lambda production and you have a low ratio. So we can look at this and help diagnose patients with multiple myeloma, and we can use that to help provide some prognosis information for these patients. So if you have a normal ratio, the probability of progressing from an MGUS, for example, is much less if your ratio is normal than someone who has an abnormal ratio. And from large clinical trials, it's shown that the higher the ratio, the higher the risk for that patient and potentially the worst prognosis. But a lot of that is changing based on treatment now. We can also monitor these serum-free light chains. There is a small portion of patients that don't produce a measurable immunoglobulin, so we can't monitor it by serum protein electrophoresis, but they're always generating the serum-free light chains. So we can monitor the presence of the ratio and the absolute concentration of the kappa or lambda when we are monitoring patients over time. So what do we do in the lab, sort of as a whole for our myeloma clinic? In biochemistry and hematology, we have a sort of a diagnosis or initial assessment panel that we've generated where we look at all the different components in the blood. We can look at a bone marrow biopsy. We do flow cytometry and genetics on when there's a patient that is diagnosed with multiple myeloma. We also look at the the urine, looking for protein immunoglobulins and creatinine and other components and protein in the urine. And then patients that are being followed, whether they're MGUS on a yearly basis, or if they're on treatment for multiple myeloma, we generally follow them monthly. So we measure all of these parameters every month on these patients. And depending some of the patients, we also measure their urine. So we have a full assessment in our lab for all these multiple myeloma patients and provide all these results for diagnosis and monitoring of our myeloma patients. So really, that's what I had to say. I'm happy to take any questions.
Thank you so much, Dr. Booth. Of course, we will start gathering the questions. In the meantime, I would like to thank you for the great explanations, but also thank all biochemists and technicians for all the great work that you do. Quite impressive. When I look at all this presentation, I feel like I want to go back to school. It's so interesting to learn all that stuff. And thank you for the images and animation. I think all this contributes to have a better understanding and make it simple for everything that is pretty technical, actually.
I hope I made it simple enough. Some of it can be pretty technical.
Well, it was for me, and I'm totally not a nerd, so.
I am a
I
nerd.
think we take for granted when we go for blood work. What happens between the time that the blood is drawn and the moment that we can, check our phone for our results. We take for granted everything that's happening, the people that are involved, the technology, the science, the innovation. You're talking about all, I realized that the tops of the blood tubes meant something, but I had no idea even something as simple as the order in which you draw the blood could really impact the results. So there are so many nuances. So many.
Those caps, color coding, I feel it's kind of a Poka-yoke method as well to make sure, they identify and make, less errors, I guess, facilitating all the work.
All color coded, so we don't make a mistake, and we get the right tube. So.
Okay, so we've got a few questions, Dr. Booth, and if you don't know any of the answers to these questions, or if it's not you specifically, feel free to just say, I'm probably not the best person to answer this. So the first two questions we got were actually about rouleau, when you were discussing rouleau and you were showing the two different pictures. So does the width of the red cell distribution, is that a measure of rouleau as well? Because you talked about how they bound together.
Yeah, so when the CBC analyzer is counting them, it actually makes sure to separate all the cells. So it's not actually looking at the rouleau itself. So the CBC analyzer separates them all. And therefore, the red cell distribution width actually isn't measuring rouleau. It's actually measuring how big or small the red cells are. And that's often to help identify anemia. So you can have microcytic anemia, small red cell anemia, or macrocytic anemia, large red cell anemia. And there's a number of underlying causes that can that. But it's really more in terms of looking at the size of the individual cells.
Okay, so then we had a question that if rouleau is present in CBC, how come we can't detect myeloma earlier?
So the rouleau one is present when there's generally very high concentrations of protein. So it's often sort of late stage. Many patients are identified with relatively low concentrations of immunoglobulins in their blood, 2, 3, 5, 10 grams per liter. When patients get up to 20 or 30 grams per liter, this is when the rouleau really starts to happen. So it's not always identified. And rouleau is actually present in any time there is an increase in protein. So it doesn't have to be multiple myeloma. It can be infection or other scenarios. But if it is seen, then it's definitely, generally it's reviewed and it is reported. So a physician would recognize that rouleau is present, and then it would be up to whoever ordered that test to follow up with.
Okay. So it's not a unique marker specifically to myeloma in that way?
No. It's characteristic, but there are other causes for rouleau.
Okay. So then we have, of course, the question, is electrophoresis an expensive test? Because, of course, early detection, being able to diagnose somebody at an MGUS stage as opposed to when they are, myeloma's fully present? Could this become, if electrophoresis isn't expensive, could it be something that could be a standard test at, say, age 65?
So this is a really interesting question, because you're really getting at something called population screening. So the electrophoresis test isn't terribly expensive. It's laborious, so we can only do so many. We do about 100 a day, and that maxes us out.
Right.
But if, for example, we were to do screening on everybody over 65, a large portion of individuals actually have MGUS, as they age. But the majority of people with MGUS don't actually ever end up with multiple myeloma. So this becomes a whole question of identifying the presence of a condition that may or may not lead to disease. And this can cause a lot of angst, a lot of worry, a lot of anxiety for certain patients. It can be quite expensive to the healthcare system if we're following these individuals and treating them. Yes, by all means, it would identify more cases of multiple myeloma, but there's an offset. So this is really in the domain of public health, and to decide from there. But in terms of why it's ordered, there are numerous guidelines that suggest, any sort of back pain or anemia. It's ordered quite frequently to try and get at patients with myeloma.
Okay, so I get what you're saying with that as well, just because there's many conditions, for example, that people don't know that they have, and they never end up developing into anything. Something I think about is an aneurysm. I think there's about 10% of the population that have an aneurysm. And that doesn't mean it's going to rupture and it's going to cause any issues. But, finding out that you have this living in your brain, how does that impact you day to day? Are you worrying about it now forever every time you get a headache or whatever happens? So totally makes sense. So we have a question.
It's a question, and it's a tough answer.
It's a good, yes, I agree. So are the excess plasma cells in the bone marrow with multiple myeloma considered myeloma? So when you are MRD negative, would the plasma cells in the bone marrow look like a normal amount?
Yes. So the excess plasma cells that are present in the bone marrow, those are indeed the malignant cells that we're looking at. And if someone is MRD negative, so that's minimal residual disease, where we're looking at very, very low concentrations of disease, their bone marrow would likely look normal. So you wouldn't be seeing it. And that's where we're using molecular techniques to find very, very low concentrations of malignant cells, far less than pathologists would be able to see under a microscope.
Okay. So our next question is actually from someone that you met last year at the CBA conference, who spoke with me. He's asking, the first part of the question is do you have any comments about someone who does some exercise, like physical exercise, before they go for blood work? And then I know we had heard at the conference just talking about a blood test that could possibly one day replace bone marrow. And is there any progress in that?
Yeah. So in terms of doing exercise, it's not really going to affect anything we do in the lab. Feel free, exercise away. I think there's only positive benefits from exercise, so it's not going to affect anything in the lab in any way. In terms of, I think what the question is looking at minimal residual disease testing from the blood rather than having to do a bone marrow biopsy, which is really where we would really want to go with this, is minimally invasive testing, blood work. And there are a number of different tests that are currently in development to look at minimal residual disease. And I think many of them are quite close to sort of routine clinical use. I think in the next, sort of 3 to 5 years, we'll start to see MRD testing in the blood, which is comparable to MRD testing that we see in the bone marrow. There are a couple of labs in Canada that are looking at that, and Cebia, which is a supplier, a company that produces our protein electrophoresis equipment, one of the vendors, they're looking at working up a test, and it's not quite ready for sort of clinical use yet, but I think very shortly it will be. And then there will be a lot more of this testing that will happen.
Yes, and for those of you on the call who are interested in this, we actually had a webinar a few months ago by Dory Abelman, who's a PhD candidate at U of T, and that's exactly kind of what his team is looking at, is developing, you know, a blood test that could possibly one day replace the bone marrow biopsy. Because for those of you with myeloma on the call, you know that that is not your favorite part of your journey with myeloma, that's for sure. So we have another question. Aside from the KL ratio, are the absolute levels of K and L light chains important?
So they can be important, and it's really when you have increases of one specific light chain over the other. So there's a number of conditions that can cause increases in both kappa and lambda. Sort of inflammation and renal disease increases both kappa and lambda, and you can get quite high values in the hundreds or 500s for kappa and lambda together. But in terms of multiple myeloma, looking at the ratio, or when you have an individual kappa or an individual lambda that's increased, is more relevant. There's no specific cutoffs other than the ratio for determination of sort of any sort of prognosis. But when we're following the patient, following the absolute levels of kappa or lambda would be relevant. So if it's going from highly elevated to sort of the normal range, that would be suggestive that the disease is being treated effectively.
Okay, the next question, I don't know if you can answer, but it is quite interesting. So somebody shared with us that they were a plasma platelet donor through the Canadian Blood Services, and the lab detected an abnormal protein in their donation and suggested that they would contact their family doctor, who then referred them to a hematologist, who then diagnosed them with MGUS. And then eventually did move to having multiple myeloma. So is this an unusual way to get diagnosed?
No, well, I think it's probably rare. But we're actually one of the labs that does the testing for Canada Blood Services for multiple myeloma. So all of the donors are screened with protein electrophoresis. And when they see an abnormality, they usually refer it to our lab, actually in Ottawa. So we do a lot of this. There's different centers across Canada. And we would identify the presence of a monoclonal protein, and we'd refer it back to CBS, who then would contact the family doctor. So this does happen, and we do identify a few patients per year with this. So
Okay.
it's uncommon, but not unusual.
Encouraging people to donate blood.
Okay, so at ASH, the American Society of Hematology 2024, there was a paper that concluded that 24-hour urine testing was not very effective in directing treatment, and suggesting that a 24-hour urine may not be used. What are your comments on that? Is this likely? What do you think?
I understand. For a long time now, people have been looking at using serum-free light chains sort of as a indirect marker of or replacing what we do in the urine, because in the urine we're usually looking for light chains in the urine because they're easily generated and they pass through the kidney and accumulate in the urine. So the serum-free light chain test has been touted as a replacement for urine analysis. The need for a 24-hour urine, currently it's still in the guidelines. There's additional information you can gain from doing urine analysis in terms of identifying the number of protein and what types of proteins are present in the urine. I think there's a decrease in the number of urines that we're testing. And in our lab, in our group, usually for the initial assessment, they do a 24-hour urine. And after that, we just look at random urines. And in our hands, they seem to be somewhat similar. And we actually have a study going right now to see if we can supplant the 24-hour urine with randoms, but don't know if we'll be able to do that or not. But there has been suggestion to get rid of urine testing for some time. But I think the urine testing does add a little bit of information to the patient.
Thank you, Dr. Booth. And I know we're over time here by a minute, but we just have one more question.
No
So, which marker or indicator would be the primary offender that could lead to fatigue?
That's tough, but I think fatigue, this is common across many sort of conditions, inflammatory or malignant or whatnot. Anemia, low hemoglobin definitely would be something that would be an indicator of potentially an indicator of fatigue, and is often seen when your hemoglobin is low. You tend to be tired and maybe somewhat breathless. So, but we don't have we'll call it a fatigue biomarker per se. So.
Also, too, when it comes to treatments as well, fatigue can also be a
side
effect of treatment in general, and maybe not something that's in your blood necessarily.
Yeah.
Okay, Dr. Booth, thank you so much for your time today. Thank you for putting together such a fantastic slideshow that was very detailed. Your analogies were great, especially when you talked about sun and clouds, because for us folk who don't have the big scientific background, sometimes we need those things just to really understand what's happening. So I am certain that you took very difficult concepts today and broke them down in a much simpler way for us to be able to digest. So that is not an easy thing to do. So we appreciate you for doing that and for having your time being with us today. And for all of you who joined us on this webinar, thank you for spending, a part of your day with us. And as Kaden mentioned, we will be putting this on our YouTube channel, so you can go back and review it, send it to friends, whomever you think need to have a watch and have an extra listen. So thank you again, Dr. Booth. We appreciate you.
Thanks for having me. It was fun.
Thank you. And just a bit of wrap up to remind everybody, if you want more information about the blood test, you can always refer to our info guide at myeloma.ca in our resource library about understanding your blood, or maybe pain and fatigue. Info guide could be interesting too for that person who was asking about fatigue. So thank you again. Hope to see you at another conference, hopefully.
I hope so too.
See you soon.
Yes.
Thank you.
Thank you, everyone.
Thank you.
Take care.